it gives me great pleasure to introduce our session director, Dr. Santosh Kumar Devdas, medical oncologist from Bangalore. Sir, are you there? So can I request you to introduce our chairpersons and our first speaker? Thank you, sir.
Is Dr. Harimanan there?
Yes, very much. Yeah.
Good morning, sir. It's a pleasure having you here. The chairperson for today's session is Dr. Harimanan, a professor, previously from Tata Memorial, right now in St. John's Hospital. Our speaker for the day is Dr. Deepan Rajamanickam. He is from Thangam Cancer Center in Namakkal. This talk will be followed by a session which is moderated by Dr. Hemant Malhotra, who needs no introduction. The panelists would be Deepan, Dr. Lingaraj from TMH, Ashutosh Daga from Narayan Hridayalaya, and hematologist from Narayan Hridayalaya Sisir Patra, and pathologist from Narayan Hridayalaya Devmai Banerjee. Please, Dr. Deepan, you can start your session.
So we also request the chairperson to also be a part of the panel.
Hi, Harimanan sir.
Hello, Deepan.
Good afternoon all.
Yeah.
Okay. So, why DLBCL? DLBCL is the most commonest type of NHL, and we all know that if we treat 100 people, at least 30 to 35 will relapse, and treating a relapsed DLBCL is actually difficult. So, what is the cell of origin? It arises from the antigen-exposed germinal center B cells. It is separated from other LBCL such as high-grade B-cell lymphoma, PMBCL, and PCNSL. And these are very heterogeneous. DLBCL is a heterogeneous disease. Not all respond to R-CHOP equally. So this is what happens when a patient comes to you. They get a biopsy from the most accessible site, and then a histopath report comes along with immunohistochemistry, and then further molecular testing by FISH, and now recently gene expression profiling. So how to prognosticate other than other clinical parameters like the IPI or the RIPI? So this is since 2004. This is the Hans algorithm, IHC, which determines whether the DLBCL subtype is GCB or activated B cell. What problem in this is, right now, in the post-rituximab era, it did not prognosticate well. So people treated with rituximab, they did not show a difference in GCB and ABC subtypes, the outcomes. And 10 to 25% were misclassified when compared to the gene expression profiling methods. Double hit and double expressor. Double expressor is overexpression of MYC and BCL2 by IHC. Double hit is you have a MYC rearrangement and translocation of BCL2 or BCL6. Double hits are usually of the GCB variety. DLBCL prognosis over the years, 5-year overall survival, germinal center is around 76%, non-germinal center 56%, double expressor 54%, and double hit 35%. The prognostic scores that we have been using for the past 2 decades, the NCCN IPI and the IPI or the RIPI, they subgroup them into low intermediate, high intermediate, and high. And overall survival ranges from low is around 90%, low intermediate is around 80%, high intermediate is 60%, and low and high is around 50%. Are there any better ways to prognosticate? Gene expression profiling. These were the 2 platforms that came in the beginning. They used only fresh tissue because they couldn't do it on the archival tissue. So the numbers are little less. The 2 platforms are Lens GEP and Lymph2CX. Now these subgrouped according to various recurring mutations that were found on gene expression profiling into 4 or 3 subgroups or the quartiles, and survival according to that is shown in the graph. DLBCL biologically is very diverse. In the GCB subtype, you see mutations involving the BCL2 and activation pathways are shown. And if in the EZB you have a MYC rearrangement, they did poor rather than those who didn't have a MYC rearrangement. In the ABC subtype, the MCD or the N1, they have mutations in mid-88 and Notch1 signaling pathways activating NF-kappa B, which renders them poor prognostic. So, role of PET-CT, Lugano classification, staging. Now PET is considered the standard of care for staging. It is much better than CT in detecting nodal and extranodal disease in NHL. We still use the modified Ann Arbor classification for staging. A routine bone marrow biopsy is not required for most DLBCL. There was a study with 654 patients. The sensitivity was 88.7 and specificity 99.8. There was a 3.1% false negative rate. The end of treatment again is assessed by PET, which is more accurate than CT in especially CRU or PR or extranodal disease. There should be at least a minimum of 3 weeks, preferably 6 to 8 weeks between the last chemotherapy and your PET assessment. Other ways to prognosticate with PET. Now currently we use the dual score visual assessment. Other studies use total metabolic tumor volume and delta SUV max for prognosticating response. A small word on circulating tumor DNA. All lymphomas have measurable ctDNA. Unique mutations detected in the ctDNA may not be detected in the tumor tissue because we get only a small chunk of biopsy. And clinical associations, baseline ctDNA corresponds with the tumor burden, and ctDNA can assess response also and pick up early relapses. The rise in ctDNA precedes at least by 3.5 months than the clinical relapse. Frontline therapy in limited stage DLBCL. Pre-rituximab era, the SWOG 8736 established that 3 cycles CHOP plus consolidative RT is better than 8 cycles CHOP, but their long-term follow-up, they still had continued risk of relapse in both groups. In the rituximab era, SWOG 0014, 3 cycles R-CHOP plus consolidative RT established that R-CHOP plus RT is the standard of care. Median follow-up of 12 years, still median PFS and OS is not reached. Current considerations in limited stage disease, you try to de-escalation of therapy. Limited stage disease, the OS is crossing around 90 and 95%, so try to reduce toxicity and trying to avoid RT. So there's a reconsideration of RT, optimal length of chemoimmunotherapy, role of response adapted therapy using IPET. These are few studies that are done in limited stage DLBCL. The ones that I would like to highlight will be the Lisa-Gillums, which try to avoid RT, and the Flyer and S101, which try to reduce the chemotherapy number of chemotherapy cycles. So the Lisa-Gillums, December 2014 was presented. 334 patients, early stage, non-bulky, 7 centimeters was the cutoff. 4 cycles R-CHOP, then a PET-CT was done. If they were in CMR, they were randomized to receive consolidation RT or observation. 5-year OS and 5-year PFS was equal in both groups. So we can try and avoid RT in select patients. The Flyer study published in Lancet 2019, 592 patients, less than 60 years of age. Early stage, non-bulky, 7.5 centimeter was the cutoff. 6 cycles R-CHOP versus 4 cycles R-CHOP plus 2 doses of rituximab. Median follow-up of 5.5 years, 3-year PFS was similar in both groups. So abbreviated chemo course also can be done in limited stage disease. This was presented in JCO 2020, the S1001. This had interim PET-based approach. Non-bulky disease, 10 centimeters was the cutoff. Stage 1 to DLBCL, received 3 cycles of R-CHOP or 6 cycles of R-CHOP. There were 2 arms. In the 3 cycles of R-CHOP, you had an interim PET done after 3 cycles. And if you were PET negative, you just went on to receive 1 more R-CHOP. If you were PET positive, you received consolidation RT as well as ibrutinib, which is a radioimmunotherapy.
insurance centers.
And PFS and OS in both these groups were similar. So R-CHOP 3 to 4 is a new standard, less morbid approach in limited stage DLBCL for the absolute majority of patients receiving radiation for the small subset of patients with interim PET positive disease. Frontline therapy in advanced DLBCL, we know that in advanced DLBCL, no matter what you do, at least 40 people are going to come back with the recurrent disease. So it accounts for 60 to 70% of DLBCL. Last 2 decades, R-CHOP was the standard of care. Cure only in 60% of de novo DLBCL cases. Now, attempts have been made to dose intensify and improve the response rates and CR rates. Dose intensification, that is day 14 R-CHOP. Other CD20 monoclonal antibody like obinutuzumab. Infusional versus bolus like R-CHOP versus EPOC. R-CHOP plus sex like ibrutinib, lenalidomide, bortezomib, and dose-dense rituximab. This is the list of phase 3 trials challenging R-CHOP in DLBCL. All were negative. Nothing could prove much better than R-CHOP except the REMARK study, which showed a positive benefit in elderly people with maintenance lenalidomide, and currently the Polaris study, which showed polituzumab had a better PFS benefit. What about CAR T cells in high risk DLBCL upfront? So this study enrolled high risk LBCL, that is the doublet and the triplet, or LBCL with an IPI of more than 3. It was a dynamic risk assessment, that is positive PET after 2 cycles of CD20 antibody therapy and anthracyclines, age above 18 years. When they were enrolled, leukapheresis was done and CAR T cells were prepared. After 2 cycles, if they had a PET positivity, they went on to receive conditioning regimen for axicell infusion, which is the CAR T cell, fludarabine plus cyclophosphamide, and then they received axicell single infusion, 2 into 10 per 6 CAR T cells per kg on day 0. It had a very good response, and the duration of response also was very good. The progression-free survival of 74.6 at 12 months and overall survival of 90.6 at 12 months. That was a phase 2 study that was published in ASH 2021. And Polarix study design, it was a randomized double-blind Polarix phase 3 trial, which used polatuzumab, which is the anti-CD79B monoclonal antibody, instead of vincristine. Previously untreated DLBCLs were taken with a high IPI, and each arm, the arm which did not receive vincristine received polatuzumab placebo, and the arm which received polatuzumab received vincristine placebo. They received 6 cycles of the same, and which was followed by 2 doses of rituximab single agent also. And if you see the results, an absolute 7% benefit in PFS, and there was a 27% reduction in the relative risk of disease progression, relapse, or death, and an absolute at 24 months. What about dose adjusted REBOC? This is a intergroup trial, CalGB 50303, published in JCO in 2019, enrolled stage 2 to 4 untreated de novo DLBCLs, 465 patients. Primary endpoint was EFS. There were more patients that discontinued treatment who were on DA-REPOC rather than R-CHOP, and the efficacy and the progression-free survival and the overall survival were similar in both groups. Topic of debate, CNS prophylaxis. Historically, who do we tell to do a CSF study? High, intermediate, or high risk IPI, testicular epidural sinus involvement, breast, ovarian, concordant bone marrow involvement, renal and adrenal involvements, numerous extranodal disease, elevated LDH, and c-MYC gene rearrangements. So, now, unlike ALL, which has a 30% chance of CNS relapse, DLBCL has only a 5% chance of CNS relapse, and upfront CNS disease is found only in 1%. But once they develop a CNS disease, their median survival is only 2.2 months. Down is the CNS IPI score. Low risk 0 to 1, intermediate risk 2 to 3, and high risk 4 to 6. which route is the best. So first you identify the risk, CNS risk, how whether they're intermediate and high risk. Intermediate and high risk, they currently they ideally receive high dose methotrexate or intrathecal methotrexate, which are the two modalities. High dose methotrexate, you have intercalated high dose methotrexate or end of treatment methotrexate. Now, these are recently published in 2022, single route CNS prophylaxis for aggressive non-Hodgkin lymphoma, real world outcomes in 21 US academic institutions. Retrospective analysis, 1,162 patients. And they concluded that there was no significant difference in CNS relapse rates between routes of administration. Relapse rates among high-risk subgroups remain elevated. So whoever was said to be CNS IPI high would have relapsed whether they received HDMTX or ITMTX. This was also another meta-analysis, 36 studies, 5 RCTs, 1 clinical trial and 30 observational studies. This in the rituximab era showed none of the intravenous intrathecal administration or novel target agents could significantly decrease CNS relapse rates in high-risk CNS patients. Treating elderly and less fit, treatment-related mortality is a concern in the first 2 cycles. So what is the role of prephase therapy? Prephase, they used either vincristine and prednisolone or prednisolone alone or rituximab with prednisolone, which reduced the risk of mortality in the first 2 cycles, and then further on enable these elderly patients to complete the therapy. Dose intensity in older patients, when you decrease the dose less than 80%, if you were aged 70 to 79, you had a significant difference in survival. Above 80, it doesn't matter whether you decrease the dose or whether it was 80% dose or the adequate dose was given. On the right side, we have our mini CHOP, the GILA study in DLBCL. This is a reduced dose of cyclophosphamide, vincristine and prednisolone, which showed response rates and survival close to around 60%. So relapsed refractory DLBCL, there are 2 things to be seen. One is whether they are chemo refractory or chemosensitive, and the other thing is if they are transplant eligible or no. So if they are chemosensitive, then they received salvage chemotherapy followed by autologous transplant. If they are ineligible for transplant or if they are chemo refractory, you should try some other therapies like CAR T-cell therapy and other targeted therapies. So these are the approved agents, chemotherapy agents for salvage chemotherapy followed by transplant. And if you are not a transplant candidate, then you have CAR T-cell therapy, the polotusumab vedotin plus bendamustine rituximab, and recently tafasitamab plus lenalidomide. So CAR T-cells in second line, the ZUMA-1, Transform and Belinda. ZUMA-1 and Transform showed very good results with good durable responses. This is the ZUMA-7 trial. Patients who relapsed within 12 months of first line therapy or who were going on to receive autologous stem cell transplant, they were randomized to 1:1 to receive axi-cell, CAR T-cell or standard of care, which is 2 to 3 cycles of salvage chemotherapy followed by transplant. And if you see, there is a significant 4-fold greater median EFS, that is 8.3 versus 2 months in the CAR T-cell arm, 33% higher ORR rates and double the CR rates in the CAR T-cell, which was a very good result for CAR T-cell in the second line therapy. Tafasitamab, which is a FC enhanced humanized anti-CD19 monoclonal antibody. The phase 2 L-MIND study, tafasitamab plus lenalidomide in relapsed refractory DLBCL. After this, it got approved for patients who were ineligible for transplant. In vivo and in vitro studies showed that lenalidomide enhanced tafasitamab NK cell mediated ADC. So tafasitamab it's very cumbersome to give. It is weekly regimens, weekly IV injections along with the lenalidomide. CR rates are around 43%, PR rates around 14%, and if you achieved a CR, the median duration of response was not yet achieved. Median PFS is 12.1 months, median OS which is 73.7%, which is very good in relapsed setting. And according to the cell of origin also, non-GCB fared better than the GCB with tafasitamab plus lenalidomide. Second line and later lines, if you are still chemo responsive, then allogenic stem cell transplant after a salvage chemotherapy regimen is one of the options. Rest of it is targeted therapies. Targeted therapies, CAR T cell post second line. We have data from the Zuma 1, Juliet and Transcend studies, the 3 different CAR T cells that were tried in DLBCL. Other targeted agents like tafasitamab, loncastuximab, polatuzumab with bendamustine plus rituximab, selinexor, etc. and BiTE antibodies in bispecific T cell engagers in relapsed DLBCL. Mosunetuzumab had good responses, and glofitamab also had good responses. In conclusion, DLBCL is an heterogeneous disease. R-CHOP still remains the standard of care. De-escalation strategies in limited stage disease should be attempted. CNS prophylaxis, no robust evidence. Elderly, treat cautiously with adequate intensity. We know that 35% of DLBCLs relapse with poor outcomes. Research on improving upfront therapies and unmet need. Relapsed refractory DLBCL has very dismal outcomes, and cell of origin using GEP targeted research may be the way forward. Thank you.
Thank you, Deepan sir. We'll now move on to the panel discussion. It gives me great pleasure to introduce Dr. Hemant Malhotra, Senior Medical Oncologist from Jaipur. With your permission, sir, I'll introduce your panelists as well. We welcome our speaker again back on stage, Dr. Deepan Rajamanickam, Medical Oncologist from Namakkal. We have Dr. Lingaraj Nayak, who has joined us virtually, Medical Oncologist from Mumbai. Dr. Ashutosh Daga, Medical Oncologist from Kolkata. Dr. Shishir Patra, hematologist from Kolkata, and Dr. Dev Malia Banerjee, pathologist from Kolkata. We also request our session director if he can also join, Dr. Santosh Kumar Devdas. Thank you so much, sir. Thank you, sir. We also request our chairperson, Dr. Hari Menon, to be a part of the panel discussion. Thank you.
So good morning, everybody. Is Dr. Hari, are you there?
Yes, very much, very much.
Wonderful. So we will direct a lot of questions to you also, okay? And Dr. Santosh, have you please come over here? Okay. You are a panelist also. You're going to get questions too, okay? All right. So good morning, everybody. Welcome to this lymphoma session. And after a very, very nice, comprehensive talk by Deepan, in which he summarized almost all the ongoing research in the field, we will, come out with some issues right on the ground, like how are we treating patients and what is the take of the present studies and the research which is available to us in our day-to-day practice. So I'm not going to show you any studies, any survival curves, any new molecules. I'm just going to be a polling agent for you. We did post these questions on the WhatsApp group because we do really want to know the practice, the real world practice with some of the tricky questions in high-grade non-Hodgkin's lymphomas. And then we do intend to come up with a guideline document. So these gentlemen on the stage, very, expert in their fields. Where is our pathologist? Oh, great. Okay. So as I was saying, we will come up with some consensus post this discussion, and then we really hope to take this on to a publication. So I bring you greetings from the Mahatma Gandhi Medical College Hospital in Jaipur, and my most sincere thanks to the organizers for giving me this opportunity. and my panelists have already been introduced to you. And in addition to these 5 gentlemen, we have a few joining online. I think Dr. Lingaraj is online. Dr. Lingaraj, are you connected?
Yes, sir.
Wonderful. So be ready for some questions. I wish that you were physically present, but we will make do with what we have. And also Dr. Hari, as I already mentioned, and Dr. Santosh is already there on dais with us. So my first question is to Deepam, because he is the one who is the most updated and the most fresh with DLBCL knowledge. So Deepam, should IHC be done in all DLBCL patients?
Yes, IHC should be done in all DLBCL patients because it helps to prognosticate the cell of origin, because cell of origin is important in prognosticating between GCB and non-GCB subtypes, which definitely have a role in prognostication.
Okay, same question to Dr. Lingaraj. Lingaraj, are you doing an IHC for all your DLBCL patients?
Yes, sir. We do ISC for all our DLBCL patients.
Okay, that's a nice, crisp, short answer. And I can come back to my pathologist now, Dr. Devmala. There is some concern about clinicians about the reproducibility of the testing and the inter-observer variability. So what do you have to say about that?
In the DLBCL, basically the IHC is required first to confirm the diagnosis DLBCL. It is a so you can say without IHC, maximally high-grade lymphoma, it is a high-grade lymphoma. Neither is a B or T origins. So the first IHC, some pan B cell marker like CD20, PAX5, or these are CD17 alpha, they're all required for the confirmation that yes, we are dealing with a high-grade B cell lymphoma, and which is a diffuse large in appearance. Preferably DLBCL. Now the next is that key to differentiate then as much as possible by some algorithms, Hemant's algorithm, and currently adding the few more markers in the Hemant's algorithm, just to differentiate that between the germinal center or the non-germinal center origin. And some extent of idea key it is the double hit or triple hit can be there or not. Definitely in GCB or non-GCB type, there is the good concordance if you use the commonly used marker like CD10, BCL6 and MUM1, and if you add some other markers like GSET1 currently used, FOXP1 and LMO2, then the concordance is little bit higher. It is almost 80% with the gene expression profiles. And definitely the other things like the Ki67, the high proliferative Ki67 give you some idea about the aggressiveness of the disease, and some little bit idea about the chance probability of the double hit and triple hit.
Very well said. So I think everybody would like to know, each practicing oncologist would like to know whether we have a T-cell lymphoma or a B-cell lymphoma. We would certainly like to know whether CD20 is positive or not. And then of course, you would also want to know whether it is the germinal center type or the non-germinal center type. So my next question is to Dr. Ashutosh. Dr. Ashutosh is a special friend of mine because he did MD at my institution. So Dr. Ashutosh, do you treat your germinal center type DLBCL and non-germinal center DLBCL differently, or you treat them all together with R-CHOP?
So treatment wise, ABC and GCB, I don't think there's a much difference in the treatment point of view. Only thing is the prognostication. If the disease is bad, if it's ABC, then even if we treat them differently, we don't have a different outcomes. So in clinical practice, we treat them with the same regimens and the same options.
Dr. CC, would you like to comment?
Sometime in ABC type of DLBCL, we can add something medication like bortezomib we can add upfront.
So there have been 2 or 3 trials
Yes.
adding bortezomib to R-CHOP. Do you think that the results are different enough and impressive enough for that to move into practice?
In practice, actually, there is no such difference in the outcome, but we can try.
Now, suppose you have a intermediate risk DLBCL non-GCB type Monday morning, would you treat that patient with R-CHOP plus something else or only R-CHOP? No fence sitting, yes or no?
Initially, yes, R-CHOP is the best.
So, Dr. Hari, can you come in, you are one of the country's foremost lymphoma experts. So when you have a patient, do you change treatment as per the cell of origin, or everybody gets the same treatment?
As of now, it's the same treatment with the R-CHOP regimen, because none of the data has actually benefited from addition of a newer molecule, whether it be bortezomib or ibrutinib, or even for that lenalidomide, except in a few subset patients. So there would be a benefit in knowing some of the marker, especially whether, at least broadly, whether this is likely to be a GCB or an ABC type, for us to even consider. But overall, we do not exercise the option of any of these molecules over and above R-CHOP when we treat diffuse large B-cell lymphoma in the first line setting.
Thank you, Hari. That was, nice and crisp and categorical and no fence sitting. Dr. Santosh, do you agree? How would you treat your patients? Anything different?
No, sir. I absolutely agree with the previous speakers. There is no change. There is no data as of now to change therapy based on the GCB ABC, and most of the patients in practice do get R-CHOP.
Okay, so now let's move on to the next question for our double hit NHLs. We're talking about high-grade lymphomas. Question to Dr. Deepan. Do you treat them differently, or you still treat them with R-CHOP?
We definitely know that doublet NHL is far worse than the other non-doublet NHLs. We should try to do something differently, but as of now, there is no data to suggest that a different approach or adding a drug or intensifying therapy has a change in outcomes.
And what are the various therapies which are available? You've just reviewed the literature very comprehensively. What are the alternative regimes which have proven to be beneficial?
Only DA-R-EPOCH is what we try to use, but with a pinch of salt. Not much.
So hyper-CVAD and dose adjusted R-EPOCH are the two regimes which are most popularly used. Dr. Lingaraj, are you there? Are you connected?
Yes, sir.
Okay, tell me, what would be your approach to a patient with a double hit non-Hodgkin's lymphoma?
So, sir, it depends on the age of the patient and fitness to receive intensive therapy. And as Dr. Deepan has alluded, that it is a high-risk group. And if the patient has multiple external sites, the typical double hit that we see in clinical practice, they have multiple external sites which have high risk for CNS relapse. So in those cases, we try to give dose adjusted R-EPOCH. But if it is an early stage dose double hit that we often see also, so in those cases, probably I am okay with R-CHOP. So it depends on age, fitness, and the IPA of the patient.
Thank you. And Dr. Dev Malia, how would you confirm a double hit non-Hodgkin's lymphoma? Is IHC okay, or should all patients be confirmed by FISH?
First, sir, IHC can give you an idea, a very brief sort of idea that this lymphoma is a possibility of the double hit or triple hit. From the morphology point of view, I can say there is a previously diagnosed cases which are known as the DLBCL, not otherwise unclassified, with the features intermediate between the Burkitt and DLBCL. This particular entity, as currently we have seen, these group of tumors have the high chance of coming out as a double hit or triple hit. In morphology wise and in IHC wise, basically the tumors which have the high expression of the kind of BCL6 and BCL2, who are the less MAM1 positive, they are the good candidate for targeting fluorescent in situ hybridization for the double hit or triple hit, the MYC, BCL2 and the BCL6. But definitely the FISH is the confirmatory, and IHC cannot replace it. IHC can give a sort of idea only that the chance of getting double hit is there. Suppose the Ki67 is get the very high Ki, then the chance is good, but that does not exclude low Ki will not show you the double hit. There's a good evidence that.
So Dr. Ashutosh, if you have a patient of DLBCL in which you've done the IHC and it is a double expressor, would you think of something else other than R-CHOP, or would you get further tests done?
So prognostically, double expressors will have a bad prognosis, but treatment-wise, no.
No, would you ask for a fish in all double expressors?
So if double expressor, I will definitely ask for a fish.
And then if fish is also positive for double hit, then you would think of something else.
Yeah, so if patient is okay, PS is good, and if he can tolerate, I'll try to squeeze in the epoch.
So Hari, can you come in now, like you are going to be our port of last call. What would you do in double hit NHL?
So the thing is about whether we want to intensify our therapy for double hit lymphomas or not. There is some benefit in a more advanced stage double hit lymphomas where we might want to intensify the therapy, but there is some emerging data that if it is an early stage, which is rare to occur in a double hit lymphoma, probably giving R-CHOP just fares as well in these patients. So there may not be any great merit in us intensifying with a dose-adjusted epoch in early stage. This is just a caveat that I'm just suggesting. But in advanced stage, if you are using a dose-adjusted epoch, then the only thing is that it is useful. But then if you're looking at a transplant, after that, then it is not going to be of any benefit if you have used a dose-adjusted epoch backbone to primarily treat them. But if you have used an R-CHOP backbone to treat a double hit lymphoma irrespective of the stage, then for advanced stage disease, there may be a merit to consolidate it probably with an autologous transplant for whatever it is worth. So it is out there actually in terms of whether we need to intensify, but we may want to individualize some patients because at present, if at all there is any role for dose-adjusted epoch, it is probably in the area of double hit lymphomas. So that is something that we need to consider. And just a note on one of the things, generally when you have a double expressor lymphomas, we don't really look for double hits over there because there is no enrichment in the double expressor lymphomas. Though it is not absolute, most of the double hits are mainly seen with the germinal center B-cell lymphomas and not so much with the double expressor.
Right, and I think in addition to what you said, the performance status of the patient is also important, right?
Yes.
Great, so we'll move on. Now this question is again to Dr. Ashutosh. Ashutosh, is there any situation in which you would de-escalate treatment in early stage, good risk non-Hodgkin's lymphoma, or would you give everybody 6 cycles or 8 cycles of R-CHOP?
So if the age-adjusted IPI is 0 or 1, based on the FLAD study, I think that is the subset where I can go ahead with the 4 cycle of R-CHOP and do a reassessment if in CMR 2 more cycle of rituximab is enough. Apart from that, stage 1 non-bulky disease, I might be okay with doing a 3 cycles or 4 cycles of R-CHOP with a consolidative RT. Apart from that, I don't think so that in any of the cases we can de-escalate the treatment.
Dr. Shishir?
Yes, low IPI and stage 1A, stage 2A, we can treat with 4 cycle of R-CHOP followed by 2 cycle of rituximab. And this is enough for this, I am agreed with it.
So I think Dr. Deepam showed us some data that maybe interim PET might be important over here. Let me ask Dr. Santosh, what situations can you investigate in which you would not give 6 or 8 cycles of R-CHOP?
In any disease as such, sir, wherever the disease biology is good, there is a focus on de-escalating therapy, reduce toxicity. And lymphoma is DLBC is one of the other subsite where we are trying to de-escalate in a very good biology disease. As mentioned in the previous speakers, flyer is one data set that we use often nowadays to de-escalate, and the previous walk study where 3 R-CHOP followed by IFRT is the other strategy that is commonly used.
So I think two of the panelists have come up with the idea that you give 4 cycles of chemoimmunotherapy, meaning R-CHOP, and then 2 further cycles of rituximab. Is that data-based? I think, Deepam, you've done the fresh literature search for your presentation. Is that data-based, or is it just,
That is data-based, sir. It was in the flyer study, which was less than 60 years of age. And they received 4, and if they achieved a CMR, then they went on to receive 2 more rituximabs alone. And the others subset completed up to 6 cycles.
Great. Anybody from the audience, any comments, any questions from anybody? Are you comfortable in a curable disease, potentially curable disease, of de-escalating treatment? I mean, I kind of hesitate to, and suppose that patient relapses, which is at least a 30% chance, then there is that question in the patient's mind, and in my mind also, that if I had given 6, maybe the patient wouldn't have relapsed. But again, there is some data to suggest that you may want to think of this. Okay, so we move on to the next question, and let me ask Dr. Deepam this. Do you consider consolidation radiotherapy in patients of DLBCL with bulky disease as baseline? At baseline, no, we are not talking about response assessment.
All the limited stage studies actually excluded bulky disease, which was either 7 or 10 or whatever centimeter they took it as. And rather than putting it as bulky disease baseline, if I would radiate in the end, I will also see for response assessment during completion of therapy, and if there's any positive disease, maybe I will try to radiate. If it's PET negative at completion, I don't think I will radiate.
So even if there is clinical residual disease or there is metabolic residual disease, then radiotherapy comes in. But if you start with a large node and it disappears completely, then no.
Complete 6 cycles of CHOP, and then probably I would not radiate.
Okay, Dr. Lingaraj, would you like to take the same question? Where would you consider radiotherapy in the treatment of DLBCL?
Yes, sir. So in advanced DLBCL, if it is bulky disease to start with, and even if they achieve a complete metabolic response after 6 cycles of R-CHOP, we still give radiation at our institute. And I agree with the previous panelist also that there is data, if you use a PET adapted approach, the benefit of RT is marginal, and so nowadays we select patients based on the site of radiation. So if it is an area where I am worried about the long-term complication of radiation, I may get away with that. But if I can deliver it safely, say in the area of neck or any other area where I am not worried for that, so in that case we give for all our bulky disease, even if they are in PET CMR. Now the benefit will be marginal, but there is no definite data to say that there is no benefit. Of course, the margin will be very less.
Hari, final comment from your side? So you'll have to unmute yourself, Hari. We can't hear you. Please.
So as what I would agree with what Dr. Lingaraj said, if you have residual disease in early stage disease, then that after 3 cycles, then it can be negated by addition of radiotherapy to that, and the progression-free survival and overall survival is pretty much the same as would be for a patient who's PET negative at the end of 3 cycles. But one of the largest data did use additional radioisotope conjugates to consolidate that process. So we have to take it with a little bit of caution. But in the era of PET scans, where you have a negative PET at the end of treatment, whether it is for bulky disease or whether it is for early stage disease, then the benefit of giving radiotherapy is probably not there, and we may get away without giving radiotherapy also in that situation.
Okay, thank you. I think we are coming to that point. What happened? What did I do? Okay. So now this is the point which all of us are talking about. If you have a bulky single site disease and after 6 cycles of R-CHOP, there is residual disease, either clinical or metabolically positive, then would all of us radiate that? Would we think of suboptimal response and think of consolidation transplant? Ashutosh, can you attempt?
Yeah, so up till dual score 3, sir, I will be happy to consolidate with RT. If 4 or 5, I will try to do a biopsy. If 4 and the biopsy is negative, I will be a little bit comfortable in consolidating with RT. But if 5, then I will be a more treat it with the caution that, okay, this might be a residual site, this might be a bad disease, and this might relapse. So for up till 4, it's okay, but 5, I think I'll put in different category.
So duals 4 and duals 5, you would make a difference. Dr. Santosh?
There's no very clear-cut data for this, but I think as we all agree, majority of clinicians would give radiation to this site and wait for relapse. And if relapse happens, you salvage with a transplant later.
But consolidation stem cell transplant, you wouldn't consider
is something I would avoid. If the patient goes, some patients are cured with just RT, and if patient is cured, you may as well avoid the transplant.
Yeah, but it does give you a signal that this is probably a bad biology disease and your antennas need to be up for relapse. And is there any data for a consolidation transplant in this situation, Dr. Deepan?
There is no absolute evidence suggesting that transplant would be better. What I would do is, as he said, according to the dual score, probably rebiopsy if it is more than 4 or 5. And if it is 4 or 5, I would probably put that patient for transplant upfront.
Upfront. Okay, so both options are coming up. Okay, I think this is an important question. I'd like Dr. Shishir to take this first. For the old, frail patient or the patient with significant comorbidities, would you give standard R-CHOP? Would you tweak that? And if you tweak that, what would you give? What is your regimen of choice? And you have a lot of patients who are 70, more than 70, and who are very frail and who have a whole bunch of comorbidities.
So in case of DLBCL with frail patient, elderly frail patient, we can treat them. First, we have to evaluate the cardiological evaluation also, and we can treat with RCOP like thing, or we can give CVP, R mini CHOP. We can also consider R mini CHOP, and even we can try here bend-in-mustard rituximab like therapy. These will be my options.
So any difference of opinion from anybody on the panel? Like, yeah, Santosh, how would you treat this patient?
Sir, I think this question would be better answered by Lingaraj. He's running a randomized trial of R mini CHOP, I think, in TMH as of now.
Oh, I didn't know that. Dr. Lingaraj, can you come in? Can you tell us
Sir,
what is the trial and if you have any preliminary results which are not confidential?
No, sir, we analyzed our data of elderly DLBCL, and we are using our CEOP, that is non-anthracycline based, and we are replacing etoposide with anthracycline. And out of 220 patients were aged above 60 years, almost 120 patients were with RCEOP and 80 patients received R-CHOP. And from that data, what we found was that from the age group of 60 to 65, definitely anthracycline based regimen was better. That is, R-CHOP was way better than RCOP, and the margin was almost 12 to 13%. That is an absolute difference in disease-free survival. But above 65 onwards, like 65 to 70, we couldn't find any difference between R-CHOP and CEOP, and simply because probably those patients who received anthracycline in that age group, they couldn't receive that ideal dose intensity every 3 weeks. We had to kind of increase the duration. Some patients couldn't complete also. So that would have been the reason. So in that way, probably above 65 was the group where I think non-anthracycline based regimen still okay if you think that patient cannot tolerate anthracycline. But between 60 to 65, I think there is clear detriment if we don't use anthracycline. So hence we use our mini chop in those group of patients, especially above between 65 to 70, we use our mini chop, and 60 to 65, we definitely give our chop if it is feasible.
Yeah, thank you. And I think just the chronological age is maybe less important. The condition of the patient, the performance status, the type of comorbidities, they are kind of more important, right? Any questions, comments from the audience? Anybody wants to come in, make a comment, ask a question to the panelists? Okay, we'll move on. So this big question of CNS prophylaxis, Deepam did review some literature in high-grade lymphomas. Deepam, can you tell me your practice? Do you use CNS prophylaxis? In which group of patients and how, intrathecal or high-dose methotrexate?
Even though I presented those two papers, I'm still not, I will not go by those papers. I will still treat them with either high-dose MTX or IT-MTX.
So what is your choice? Do you usually use IT-MTX or high-dose?
My choice is usually IT-MTX only, not high-dose. And people who will I give them is with a high IPI and testiculocytes, renal, adrenal, breast with a high CNS IPI score. I would use IT. You would
use intrathecal. Dr. Hari, can we come to you? What is your impression? Oh yeah, sorry, I didn't see you. Please go ahead.
Sir, I was just telling that why is it happening again and again that trials are showing no benefit of treatment, but if you ask any expert, the practice is to give, but trials are not showing any benefit. Why it is happening so, sir?
You know, there's some things which we are morbidly frightened of, and I think CNS relapse in a high-grade lymphoma is what we are really frightened of. We want to avoid that at all costs, because if a CNS relapse happens, then the prognosis is uniformly poor. So I think that fear in our mind is driving us to continue and offer that tiny benefit if it is a benefit to these patients of ours. And I think we have accumulating data. There was one very nice article in The Blood very recently. I think Dr. Deepam reviewed that also. That there is gathering evidence that the way we are doing CNS prophylaxis just now is probably not enough. You have a comment? Please go ahead.
All those studies that I put up were all retrospective analysis, and none were prospective analysis to give treatment for CNS directed therapy. I think we need more robust evidence in the form of prospective trials to suggest whether this modality is important or not.
Okay, so I think that is a question which is still unanswered, and I actually agree with my panel that for the high-risk patient, for extranodal lymphomas, testicular lymphomas, I would not think of even not giving CNS prophylaxis. I would give CNS prophylaxis, whatever the trials might say. Agreed?
No, sir, can I just say?
Yeah, Hari, please go ahead, please.
It's not about whether you want to give CNS prophylaxis or not. It is the way that much of the data was looking at whether giving high-dose methotrexate is better than giving intrathecal. And that is something that did not show a difference at all. But that was disappointing. But intuitively, when you think about the pattern of spread, it is mainly a parenchymal involvement. You can have leptomeningeal, but perhaps leptomeningeal involvement is better served by intrathecal therapy, whereas a parenchymal would be better served by high-dose methotrexate. But what the studies did not show was that there was no, was there a difference in the two? There was no difference in the two. That is all. But the debate is not whether you want to give high-dose methotrexate, whether you want to give intrathecal, CNS prophylaxis or not. We still will go ahead with CNS prophylaxis in those patients who have a high CNS IPI, and for all those whom we feel might be requiring, has a propensity for CNS disease, which includes the testicular lymphomas and extranodal lymphomas, gastric lymphomas, bone marrow involvement. And if you look at much of the types of lymphomas, mainly the ABC type, which is probably having more of CNS disease, and that is true for primary CNS lymphomas too, which are ABC subtypes. So we have to be a little bit more guarded in accepting much of the data and see what is best for the patient. And I don't know whether I have given the correct answer, but again, just to say that it is not about whether we need to give CNS prophylaxis, it is about what is the type of CNS prophylaxis that we need to, which did not show a difference.
And what is your, thought, Hari, like should we go the ALL way if you bring in intermediate dose or high dose Ara-C, will that make a difference? Or maybe prophylactic cranial radiotherapy as you do for ALLs, used to do for ALLs and you still do for small cell lung cancers, will that make a difference?
I think the proportion of CNS disease in acute lymphatic leukemia is far, far greater than what you would encounter in a CNS lymphoma. At best, even for a double hit lymphoma, where we're looking at almost about 18 to 19% chance of CNS disease, CNS failure, as we would call it, I think it will be a little too preemptive to try and deal with that with more doses of chemotherapy based on an assumption.
Okay, thank you. So I think we'll move on. We have about a minute and a half left, one or two more questions to go. Dr. Lingaraj, I'd like to address this to you. Do you believe in interim PET-CT in DLBCL? We know that it is pretty much established in Hodgkin's disease and the post-2 cycle interim PET-CT we use to escalate or de-escalate treatment. What about DLBCL? Do you have the same strong data for DLBCL or you don't?
So, sir, for DLBCL, there is no such strong data, unlike Hodgkin, where you do interim PET and escalate therapy. There is one study that was done with this kind of approach, like intensifying after 4 cycles of R-CHOP with Burkitt kind of regimen, and that was a negative study. So, even if I know the PET report after 4 cycles, even if I intensify, there is no difference in outcome. So, in that way, end of PET remains the standard, but having said that, there is a group of patients where there is a risk of primary refractoriness. Probably those group of patients I can pick early if I do interim PET. Maybe that is based on the baseline risk assessment like high IPI, multiple external site or double hits, where I will straightforward chip in and start salvage and then go for transplant rather than continuing further R-CHOP, which is anyway not useful in those group of patients. But that will not be a big number. And again, that will be decided based on the baseline risk factors.
So if I were to conclude that interim PET is still experimental, but if you finish the treatment, then do the PET and then decide further treatment, that would be important. Is that acceptable to all the panelists? Okay. So I think we can, kind of skip this. Last question. And let me start with Dr. Ashutosh. Do you use LEN maintenance? I will take only 1 more minute. LEN maintenance.
For elderly patients where I have not given a very high intensity treatment, yes, especially for patients who are more than 70-75, not for all.
Not for all. And what about you, Dr. Santosh? In which patients would you think of LEN maintenance?
Sir, in patients whom there is a perceived risk of recurrence, based on the remark trial that used LEN maintenance showed improvement in PFS irrespective of the ABC or the GCB subtype. In patients whom there is a perceived increased risk of recurrence and you know that this patient will not get a salvage and a transplant for sure, in those patients I do encourage LEN maintenance.
Any other opinion from the panel over here on LEN maintenance? Okay, great. So I think we will wind up now, and we've had an excellent panel discussion. The questions which have been raised to us have been addressed by our panelists. And I think with that, I could summarize. All of us would like to do an IHC for DLBCL to at least know the T-type or the B-type and whether CD20 is positive or not. We would also like to know germinal center, non-germinal center, even though the treatment may be the same for both, but it would be good to prognosticate. If the patient is a double expressor, we would like to confirm by a FISH test. And for the patients who are confirmed to be double hit lymphomas, for the high risk patient and the patient in good performance status, we would consider escalating treatment from R-CHOP to maybe dose adjusted REPOC or maybe hypercVAD. If the patient has residual disease post-treatment, either clinical or metabolic, we might think of doing a rebiopsy. Think of half of the panel would like to consolidate with radiotherapy, and some of us would like to label this patient as a bad natural history disease and consider autologous stem cell transplant as a consolidation. Len maintenance is not for all patients, only for selected patients, right? So this is, kind of what we discussed. So ladies and gentlemen, please give a big round of applause to my very, very learned panel, and thank you very much. And then we wind this panel discussion now. Thank you.